Christl Donnelly is a superb statistician. She's also a superb scientist. And for me, that is the perfect qualification for a lecturer that I can choose to present a plenary. I first met Christl when she was a research student and I was a professor. My career since then has been something of a plateau. Christl, on the other hand, is now an extremely eminent, internationally known scientist, and the best and most concise summary of that is her very recent election to the Royal Society. So my personal congratulations, which I've already presented in email some time ago, but again on behalf of the Society and on behalf of myself, to my friend and colleague Christl Donnelly, and I'm very much looking forward to your lecture.
Oh, now I'm really not intimidated at all. Speaking after that. Thank you very much, Peter, and to the Society more widely for the invitation and the opportunity to speak to you. And it is an opportunity that I'm getting, but taking on behalf of a group of people, in particular in this case, the WHO Ebola response team, because there were a whole group of us who worked very hard over a number of months, and now it's stretched into years, working on Ebola epidemiology. So I thought this was a nice opportunity to demonstrate a whole range of analyses all related to the one epidemic. This is the group of 14 people who worked on Ebola full-time for at least part of the last couple of years. And of course, then it wasn't just people at Imperial. We were working as part of the WHO Ebola response team that included individuals from the affected countries, which would be Sierra Leone, Guinea, and Liberia, and also WHO staff, in particular Chris Dye and Bruce Aylward from WHO Geneva. So we were all working together to try and make the best use of the data that was available. As you're probably aware, the West African Ebola outbreak was by far the largest Ebola outbreak the world has ever seen. And while it's an extreme tragedy that it got to that point, it does mean that I think there's a responsibility on us as statisticians and statistician epidemiologists to really make the best use of the data that is available. So that, there didn't used to be very many Ebola survivors, partly because there didn't used to be very many Ebola cases. And so because so many of them died, very little was known about the sequelae of Ebola infection. And now people are able to study that. Similarly, we didn't know about how it affected different age groups, whereas now we've got such a large data set, we can estimate those things. So I'm going to try and give you a flavor for the range of work that we performed and the opportunities it presented for us to learn about the science of Ebola and disease control and the challenges that we faced. So if you look at this map, which was produced by the CDC, you will see Ebola infections in the US, in the UK, and in Russia. Two of those were lab accidents, and one of them was in an imported monkey. Except for that, you see that the outbreaks are all in Central Africa, and then you have the West African outbreak here. But until that time, all of the Ebola outbreaks had happened in Central Africa. There was actually considerable expertise that had grown up in how to control Ebola outbreaks. And so there was, in some sense, a sort of blasé attitude. Ebola, we know how to deal with that. There are experts in Congo. Even though there are many health challenges in Congo, they had a team of people who work on response to Ebola outbreaks who, once it was identified, would come in and control it. Now, there were a number of circumstances that came together that made this very difficult to control. Part of it was it took a long time before people really realized what it was and before it reached international attention. And it had gained a lot of momentum in that time. And also, the areas being affected had relatively weak healthcare systems. And so that meant it was hard to deal with local resources. So the first case was retrospectively identified as being in December 2013. By the late 2015, so about 20,000 cases. I'll give you final numbers. The last case was in April of this year. So most of the patients were young adults or young up to 45, depending on your definition. And a substantial number were healthcare workers, which was particularly important. Although 5% may not seem like a big percent of the cases to be healthcare workers, It's a lot of healthcare workers out of the number that were there in the first place. So because especially initially, people didn't have the personal protective equipment to prevent them getting sick, when they were responding, they were putting themselves directly at risk, and also, their families and their colleagues. There was data from past outbreaks about the incubation period and the serial interval. Just to remember, the incubation period is that time from infection to onset of symptoms, the serial interval being the time between generations of the disease. Incubation period is particularly important because it informs how long you have to watch somebody if you know they've been exposed to Ebola. So it's important that we understand, and of course the incubation period isn't just a fixed thing, it's a whole distribution. So one of the things we wanted to do as data became available was inform the WHO when they did contact tracing. So if I came in showing symptoms of Ebola, someone would say, okay, how many people, name the people that you've been in touch with in the last couple of weeks. And so the question was, should they be asking me for 1 week, 2 weeks, 3 weeks? Obviously, you could say, well, play it safe, we'll go for 3 weeks. On the other hand, if I name people, I'm going to name a lot more if it's 3 weeks rather than 1 probably, and that's a lot more people to have to follow up. So by having a sense of what the incubation period distribution is, you can inform directly that measure of control. I wanted to talk about as well the basic reproduction numbers. So the reproduction number is the average number of people that a typical case will infect. So for the diseases you've heard of, that's almost all over 1. The only time when that wouldn't be the case is diseases that come from animals. There are some particularly pathogenic influenzas that come, avian influenzas that come from chickens to humans, for example, but humans hardly ever spread it. So occasionally you see that in the news, but it's just because usually because somebody's gotten infected by the animal source. For the human-to-human transmitted diseases, if the basic reproduction number, that's the number of this average number of new infections you cause in a fully susceptible population, if that's less than 1, then we wouldn't have seen the disease as an outbreak. So it starts off high, and the reproduction number will then get lower, naturally because fewer people will be susceptible, either because you're thinning out the population, that's one component of it, because if people are dying or if people are becoming immune. Now, obviously, we don't want to stop epidemics by waiting until it's depleted the susceptible so much it isn't spreading. So we want to proactively do things to bring down the reproduction number. How can we do that? Well, in the case of Ebola, this personal protective equipment, it's if you find somebody is ill with what you think is Ebola, you bring in people who have the equipment and the knowledge of how to deal with that without setting themselves at high risk of disease. Also, in West Africa, there were funeral rites that facilitated transmission. For example, the washing of the dead body in water and then using that water to wash the relative who did that themselves. So this was a way of sort of honoring the dead, but of course, from a pathogen point of view, it was a way of putting the person who did that at very high risk of transmission. And so you get a conflict then between what the science-based advice was telling people they should do and what they felt was going on. And if you're talking to somebody who doesn't have a pathogen-based understanding of disease, who thinks that it's your fate, you're either going to get Ebola or die or not, it may be very difficult to convince them to stop doing something that they feel is necessary for the honor of the person who's just died and would reduce the risk to themselves. So the first case was in Gekadu, which is in Guinea, but it is critically in this corner, which is right at these 3 countries coming together. It's a very jungled area, and it meant that very quickly the transmission from Gekadu made it an international outbreak. So that was one of the things that contributed to the difficulties in spread, is if it immediately becomes an international problem, then you've got to coordinate multiple health authorities, multiple decision-making policymakers, and bring them all together. So that was just a situation that was unfortunate that it happened to be there. So what happened was, it wasn't until March that the WHO published a formal notification of Ebola in Guinea, and then it wasn't until August that there was a declaration of this being a public health emergency of international concern. Now, you may recognize that wording from Zika, which has already been also declared a public health emergency of that form. So it was later in August of 2014 that Imperial College, we received a line list, so by which I mean an Excel sort of spreadsheet which has one line of data for each individual in the database that we could then use to estimate things. So it had many, many, many variables, and they weren't anywhere near complete, but that's the sort of data set we received. So these are time series for the different cases. Obviously, I've taken this out to further than we initially got it in August 2014, but shows you the scale of cases in the 3 affected countries, and you can see how they grew. So although Guinea's where it started, the case numbers never got as high. Those are weekly case numbers. In May of 2015, Liberia was declared Ebola-free. To be Ebola-free, you have to be more than 30 days with no free Ebola cases. There was then a flare-up, and it was declared Ebola-free again in September 2015, and then Sierra Leone was declared Ebola-free in November, and Guinea discharged their last cases. So this is all coming, seeming like things were going the right direction. But then there were flare-ups, and this is detail of a flare-up in Liberia. Now, there are multiple mechanisms that would lead to this that were known beforehand. One of them is that it's clear throughout the case, throughout these example epidemics, that not all cases were identified. So there were individuals who were being identified as being Ebola cases where they couldn't link them back to other cases that had been identified before. So that meant there was some transmission that was happening, and it was believed to all be, once it started, human-to-human transmission. Also, one of the things that was found was because there are now more survivors, because there have been so many thousands of cases, there's a possibility of, in some cases, transmission from survivors. So it's known that in some bodily fluids you can find virus after the person has recovered. And so although they were testing for virus in the blood before they would release somebody, if it was in other bodily fluids, for example, there's a possibility of sexual transmission, you could get seeding of new cases. And so, of course, every new case has the potential to spread and lead to 20,000 Ebola cases if it was not controlled. So really high level of vigilance, even once it got past these 90 days, to make sure that because there are so many Ebola recovered individual survivors out there, that they don't start new epidemics. Now that's particularly difficult to deal with when you want to, on the one hand, reassure people and allow people who have survived Ebola to lead normal lives, or as normal as they can, given that they probably had members of their family who died of Ebola. On the other hand, so you want them to be accepted by the community. On the other hand, you also want to protect other people so that they don't cause new infections. And that was a difficult balance, because there were cases of where Ebola orphans were being not cared for by their extended family members because they were scared that that would bring Ebola into their household. So it's this fine balance of being both informative and evidence-based, but also realizing the difficulty in these very nuanced sort of assessments of what risk is. This gives you an example of the sort of maps that were produced by WHO. 60% of these individuals that are mapped on here, so they're all the confirmed Ebola cases, had information on what village they were from. And in that case, they were mapped to the village, but that means 40% didn't. So in that case, they were mapped to the district or the region, or if they had to, the nation from which they came, which means that when you see a relatively large lump out here in relatively the middle of nowhere in terms of the rest of the epidemic, it's probably not that the cases were concentrated right there, but that's the center of the district, and so where they're being mapped. So it is informative, but it gives, it shows some of the challenges. Now, in the spirit of openness and information, WHO was presenting maps of this or similar form for months throughout the epidemic, so people could go and look at the maps and see where recent cases had been, how many cases there were, and so on. So it helped dispel myths that, it was only, in a tiny little corner. So in June of 2016, so earlier this year, it was declared the end in all 3 countries. So that was the first time since December 2013 that it was declared Ebola-free throughout all three main affected countries, Liberia, Sierra Leone, and Guinea. So by this time, and the last case was in April, 28,000 cases had been recorded in the WHO database, and there were over 10,000 survivors. And I mentioned the risks inherent in those, but also providing these people for support. You've probably seen in the news the relapses that have been had by the nurse, the Scottish nurse who got Ebola and was brought back from West Africa and treated here. And she's had episodes of needing to be treated again. Now, in the setting of West Africa, it's very unlikely that somebody with those symptoms would have survived there, but people are trying to provide as much support as they can to these survivors and their post-viral range of symptoms that they had. For example, they found that there were eye symptoms that people get. So somebody started to go blind. It was a Western doctor who'd been infected with Ebola while treating patients, and he realized that his eye actually changed color. And it was treated. Now, it's possible, of course, that there had been similar post-viral symptoms in survivors of the other smaller outbreaks. Obviously, the rare things would be unlikely to be seen, but it was probably also the case that outsiders came in, stopped transmission, and once they were confident that transmission had stopped, left. So they probably weren't following up people the way they are now. So there's special efforts being used to follow up Ebola survivors now. So how did it work? I mentioned that we started getting databases in late August 2014. So we would get country-specific databases. We would need to clean them so they had spatial data. This was not a data set created with drop-down menus. So when somebody typed in a village, they just typed it in. So villages might be, spelled in different ways, all these sorts of things. So trying to even clear, and that was the same with districts and regions and even countries. So, we were dealing with, in Guinea, a lot of things were entered in French, trying to translate those, and they might be trying to put in accents in some particular way. So we had to clean that up a lot. There was information entered on the healthcare treatment center, if somebody had entered there, and those were just being entered free form. So you could get all sorts of different names. So, a lot of man and woman power was put into trying to actually get these into regularized formats so that we could tell as best as possible which people were actually at the same treatment center. Healthcare positions, relationships were the same. Basically anything that had to be free entered was an issue. We then tried to clean those up and combine them. We also did sort of reality checks to make sure that someone didn't die before they had onset and things like that, that were things that were impossible. Of course, somebody might have been hospitalized before they had onset because they might have been hospitalized for something different. But trying to clean up the data as well as possible. Of course, anybody who deals with data that's entered in a very frantic ways, as this was, sometimes you had the years wrong. So you would get cases that appeared to be happening in the middle of 2013, which we knew they didn't. It was just they'd entered the wrong year. It was 2014. So we tried to clean all that up as best we could, pull that together, and then set up a system of analyses that were replicable. Now, we aimed for an R-based system that involved bring the data set in, clean up the extra names that had been added, get the data set combined, press the button, and out would come a report. We aimed for this automated report. It never actually was automated. Never once did we actually get the report out with just a press of a button. But it did improve things, and it made it more replicable because we were getting databases really frequently, every couple of days. It was a situation that I had dealt with in foot and mouth disease where we were getting them daily and had managed to, in those initial enthusiasm and hard work, were producing daily outputs and analyses. And then we realized after this was going on for weeks and then months that actually doing the analyses again every day was not telling us that much more, but people were used to it. So we were doing as much as we could, getting these reports out, and we sent 37 different reports to WHO. These are informal reports that just went to WHO. Now, we were given access to this data because we were a WHO collaborating center on infectious disease modeling. It did mean, though, that we were not free to share these data with anybody else. So WHO is the one that sent us the data. We sent the reports to WHO, and they distributed them. They distributed them to people in country and other people that they felt were appropriate. But when we did get requests for the data, we had to send people back to WHO because it wasn't ours to make any decisions on. We wrote papers. We had, as a group, a couple of visits to Sierra Leone and various visits to WHO Geneva. So in terms of what were the reports, before we were improving situational awareness, which was a term that I must have come across before, but I just wasn't really aware. So telling people what's happening, making them better aware of what's going on. So we tried to look at the key delays. I mentioned the incubation period and the serial interval. What's the duration of hospitalization for survivors and those that die? Just so that people have an idea, if case numbers keep going up and people are staying in hospital for 2 weeks or 3 weeks, how many beds are we going to need? So it was important to look at those. Transmission intensity and how it varied over time. What was the severity? So what percentage of people were dying? And exposure patterns, looking at contacts. What we would have really loved but didn't have was the data that we could evaluate contact tracing on. Like if I said, okay, I'm sick now, who are the people that I've been in close enough contact that I might have given them Ebola in the last couple of weeks? They go out and get traced, and then we see if those became cases. Although we had a list of names that had been contacts at some point, we didn't have it recorded in a way that said who reported that contact. So we were unable to look at the effectiveness quite that well. But we did have people who said we did have people who reported which Ebola cases they had been in contact with in the past. So we could look at where they got disease from, but less so who they gave it to. We also had to deal with, of course, the issue of, oh, look, the epidemic is getting much better because of reporting delay. So there's always this temptation, and especially when actually efforts have come in to turn that from a growing epidemic to a declining epidemic, you still got to be really careful that you're not overestimating the impact because you haven't gotten all that data in yet. So as I mentioned, we did this cleaning. So there were in the end, about 3,000 lines of code relating to just cleaning up the data. Including all those hospitals and things. There were data that were missing, and there were these delays. So this is the top of we made this available in our first paper, which came out in September 2014. If you want in the supplementary information, you can have the whole multi-pages of the questionnaire. So it just gives you the level of detail. It is extraordinary to me, and we are extremely grateful, both as a group and I think as the scientific and public community, for the people who sat down and recorded these data while they were dealing with people who were sick with Ebola at the time. They were, putting themselves really at the very front line of this fight. And, there were cases that, and once something's in an Ebola treatment center, it doesn't go out. So there were cases where people had to stand on one side and shout out what was written on a form to somebody who's standing on the other side of the line so that they could be transcribing it and writing it down so that they could go enter it somewhere else. So people went to really extraordinary levels of effort to try and record this information. Now, some of it obviously could have been of clinical benefit with looking at the person and directly to control, but a lot of these things are that people recording it may not have seen the direct value of, but were extraordinarily lucky that they went to the effort of recording as much data as they did. Now, we're receiving these regular updates of the data and trying to turn around a report and inform people, and of course, do more sophisticated analyses as well, and import them into the automated process as well as possible. But you also need to, of course, be reliable, because if we're speedy but not reliable, that's not going to work very well either. So there's this sort of counter balance you've got to get between the quality control and trying to get people who are really tired to work as fast as they can. So, and trying to pull things together, because there are different ways, when you've got 14 people working on something, you come up with different approaches, which is great, but then we're trying to make them, as coherent as possible. And if there were discrepancies between different pieces, understand why that was. Not to cover them up, but just to understand, was it a function of the data, or was it a function of different approaches to the analysis? So this is the sort of things that we estimated. So I mentioned the reproduction numbers and these delay distributions, what's going on with mapping and the local incidence, because that was important to inform people of where do you put the next Ebola treatment center. I've got some money, the government, the UK government's given money for an Ebola treatment center, where should it go? Well, this is a high area of Ebola incidence, but you really need to know, is it going to stay high by the time you get your treatment center built? Or is it going to mean that because it's high now, by the time I get my Ebola treatment center up and running, there aren't going to be so many cases? So all of the beds were overwhelmed at various points in the outbreak, but it was, a lot of things were built, and it was important to try to anticipate where would be the next local need. So all those things fed into reports that we tried to update as often as we could. This is the first thing that we published publicly, so it looked at and this is just very simple, epidemic growth. So you take the case numbers so far and you put them on a log scale, and then a bit more sophisticated, but fit a line through it, not very much more, and project if growth, so it looked pretty much exponential growth in each of the countries, and if things continued as they were at that point, how many cases would we see over the next few weeks or months? And so we were able to do that. And we were able to show that in all three countries that that's a reproduction number over time. So it's not R naught because it's not a fully susceptible population, but it was still significantly over 1 in all three countries, which was really important because it meant there was still a lot of work to be done. The doubling time ranged from 15 days in Guinea to 30 days in Sierra Leone. So if you imagine being overwhelmed in a situation, and then the cases are going to be twice as many per day in 2 weeks' time. And so we estimated that at this current level of increase, assuming no changes in control efforts, that by the beginning of November, there would be over 20,000 cases in total. So this was a prediction. And when I did the press conference in WHO, a press briefing, WHO with Christl Donnelly, who's the director of strategy from WHO, and one of the things they said to us was, what if you're wrong? And we said, actually, we want to be wrong in this, in that we don't want to be in a situation where there are no changes in further control. We want there to be further changes. This is showing the implications of what would happen if there weren't. So it was not a sort of prediction of this is what we think is going to happen, and certainly not what we ever wanted to happen, but what would happen if nothing improved. And so that's what we presented. And then there was an update, and things did improve. So there wasn't so much growth in the epidemic. By the time you see this, you're sort of getting a stabilization toward the end of 2014. And so one of the things that people were asking at this point, so this was published in the very end of 2014, was, is the reproduction number less than 1? And it wasn't significantly less than 1, because you can see that from the fact that the confidence intervals fan out of what could happen in future. So it could still be that the reproduction numbers at that point, even if they stayed stable, were still slightly above 1. So although it looked much better than the situation in September, still more needed to be done. We looked at the age distribution and how things changed through time. And if you look at the case fatality rate, one of the things that we were able to show, because we had so many more children affected than had been in previous epidemics, that the best age to be as an Ebola case was a teenager. So you want to be big and not aged. So the highest case fatality rates in children were in the very youngest ones, and also they tended to die, the ones that did die died more quickly. But it was relatively small numbers, especially at the beginning of Ebola cases. Now, of course, this is of cases that we knew about, and there are issues of, trying to figure out if there had been more child cases that had been missed than showed up in the databases. But it's a non-negligible proportion. By the end of this time period, sort of about 30% of cases were children. So what we did in further analysis in looking at diagnostics was try to look at what had been done in the past was a PCR case for testing. So here's some people who get sent as possibly having Ebola. And if they're tested, which goes to PCR, and a PCR can take a couple of days to get back. In some cases, a number of days. So in that case, the ones that Harriet Mills did this, came up with this graphic. So the ones that are red are infected, and so they all get bled. And then the ones that are found to be positive get get hospitalized, and these people get released. But unfortunately, this person here is one person who came in as uninfected, but was infected in the process of being held in the holding center. So what we looked at was whether or not the use of a rapid diagnostic test, which I would say was not available at the beginning of this epidemic, but has become available over the course of this. If we had that rapid diagnostic test, and even if it's not fully accurate, how accurate did it need to be that it would be useful for putting people in low risk and high risk while they waited to get their PCR results, and then on the basis of their PCR results would then be told whether or not they were going to be released. And then you could be in a situation where you used the rapid diagnostic test only and sent people home or into hospital on the basis of that. And so I thought, because people might think, given the group that I'm in, that this would all be transmission dynamics, even though it said statistical insight. This is the one bit that has a transmission model, so dynamical partial differential equations moving people from susceptibles, S, into exposed, into infecteds, which showing symptoms of the disease. So I'll just wave my hands a bit about those. And so you can see here, red was the fit to the model fit to the Sierra Leone epidemic using the PCR only scenario, which is what actually occurred in the outbreak. And we showed what the impact of different levels of testing would be. So the yellow, which is the most extremely good case in terms of preventing new infections, was having a near perfect rapid diagnostic test. The rapid diagnostic test worked as well as the PCR. So that, of course, then you wouldn't use anything else. If you could get an accurate result in a speedy way, you would use that. But this shows a sort of reduction in case numbers you would have by actually getting people diagnosed and relatively out of harm's way, by getting them out of the holding center. So if they could have the test result in just a couple of hours rather than days. In terms of comparing males and females, there was a lot of concern about women being preferentially infected, that there were a lot of female cases. We looked at this actually, although there were the occasional small outbreak where there were more women than men, there were also small pockets of infection that was more men than women. For example, a fishing area where it was almost all male fishermen who were infected. What we looked at in terms of the delays was where we had the estimate of infection to onset to hospitalization, and then time to discharge or death, depending on whether or not people survived. And what we found was that men spend half a day on average longer in the community than females do. Now, this was a significant result, and you can see if you compare all three countries, it shows up separately in Liberia, Sierra Leone, and Guinea. So it's definitely significant. So there was an issue, though, of us publishing this. The WHO was concerned that people would fixate too much on, that means we need to get men in sooner, rather than we need to get everybody in sooner. Because their issue was, okay, yes, the males are half a day longer, but actually males and females are both too long. So what does that mean in terms of the intervention? Should you actually be preferentially trying to target the message to men or get the both? So, of course, everybody needed to get in sooner after showing symptoms of the disease, but we did find that systematic difference. The other thing we found was that women were less likely to die. So you can see sort of the estimates divided up by age. So I showed you how it was best to be a teenager in terms of the case fatality rate, and it was high in very young children. It also gets progressively higher as we age. So that was consistent with both men and women, but we found these differences. And these were things that hadn't been seen before because there weren't, we hadn't been able to subdivide the data up into such small age groups and gender-specific groups before because of the lack of cases. So there was one of the sub-analyses were looking at exposures that were reported. And so this shows for the people who reported exposures, so these are to other cases before they became a case themselves, and we estimate that the majority of reported exposures were with family members, either close or extended families. Now, that could mean that that's because there's more transmission between families. It also could be that I more reliably will be able to tell you that this family member that I had contact with became an Ebola case than a distant acquaintance that I had contact with 5 days ago became an Ebola case. So it's something that we have to be careful about because the families may be more likely to be reported, but it still suggests that there could be a lot done within family exposure. And that's partly having more healthcare facilities available, because there were times when there was there were videos shown in the news of someone who brought their young adult son to a treatment center, and he was lying on the ground, clearly suffering from all the symptoms of Ebola, but the door was shut and they wouldn't let anybody in because the treatment center was full. And so situations like that where people have, read what the public health messages of if somebody's sick, get them seen to, and then they tried to bring him in, so what are they supposed to do? Leave him there, take him home? It's just impossible situations people were put in. But, so you need the resources as well as the messages. This is looking at healthcare workers. So if you look at the healthcare workers, and there were, whether or not you look at non-funeral exposures or funeral-related exposures, you see less in the way for this subgroup of family exposure, although it's still dominant in the funeral ones. But you see much more healthcare exposure, which is what you'd expect. They're healthcare workers. They probably got exposed to the healthcare system in many cases. Funeral exposures were important. As I mentioned, sort of the funeral rites. Another thing was, even for the people who didn't wash themselves in water that the corpse had been washed in, there was still, in many cases, handling of the body as a traditional way of dealing with it. So there was a necessity of coming up with burial teams, but they were aiming for a safe and dignified burial, because one of the concerns was that a safe burial was being treated without dignity at all, and that discouraged people from reporting, well, either if somebody had died and they were afraid that they would then just be thrown in a pit and not given any sort of appropriate sort of handling, or if someone was very sick and thinking, well, they're going to die anyway, and I want to give them my own sort of funeral. In terms of looking at the population level determinants, one of the analyses that we did based on the transmission was looking at, this is the monthly reproduction number, so it varied. So these are the estimates. Now, I'd like a show of hands. This is something that was an issue within our group. So the points here are represented by small and large circles, and the big circles represent those with the most weight. Now, I tend to see things as you put a sort of confidence interval equivalent around something, so something with a big circle is very uncertain. So the fact that this doesn't fit through the little point here is not an issue. So, as a show of hands, what people would have put the big circles on the precise points? Peter, okay, a few more people. We would have put the circles on the big circles on the imprecise points. A few more. Some people wouldn't have put circles on anything. But this is what we ended up with. So the big circles are for a lot of weight, and it shows that the monthly percent of reporting of funeral exposure, so if there were more funeral exposures reported, then there was a higher reproduction number. So funerals, it's important to get funerals down. And also, if you increase the proportion that get hospitalized in less than or equal to 4 days after they had onset, you will decrease R. So those are both things that you'd expect. If you reduce funeral exposures, you should reduce transmission. If you increase speedy hospitalization, you should decrease transmission. We also looked at the case fatality rate by different treatment centers and looked at extra-binomial variation. So this shows looking for the presence of extra-binomial variation by district. And so here you see points plotted as a function of their number of cases and what their case fatality rate was. And the solid line represents the bounds for the 95% of points you'd expect. The distribution of 95% would be between the solid lines. 97.5 would be between the dotted lines, and you can see a number of points outside of there. However, once you adjust for case mix, like more males or females, what the age distribution was, and how long it had been from the time the person had onset till they became hospitalized, it's not just the points outside the dotted lines. The ones represented here in squares represent significantly lower than we'd expect. So in the bottom, 2.5% case fatality ratio. So some of those were below the just default lines. And then these in the diamonds represent ones with higher than expected case fatality rates. This is important because, of course, people initially didn't look at it this way. They just wanted raw numbers. You know, what was the proportion that died? So we also did this looking at treatment centers, because obviously if you're going to have an intervention, it's probably more based on a treatment center than a district. And in that case, only 3 points came out as significantly different than sort of unusual, I guess is a better way to put it. 1 low and 2 of them high based on their case mix. So there's a possibility people can go back and look at that, but the difficulty is that very little detail was recorded about how patients were treated. So including, you know, what facilities were available, did they have IVs available, were they used? So there's substantial heterogeneity, but even when we explain case mix, and there's a little bit of variation that we haven't explained, it's very difficult to explain. The more subtle thing is that what I've shown you for case fatality rate are only for the people for whom outcome was recorded. There's a substantial portion of the data for whom they even went to a treatment center, somebody filled out the questionnaire, and then they left the treatment center one way or the other, but nobody went back and filled in whether they died or were released. In a way, if they bothered to do the report or the questionnaire in the first place, that's surprising because it's a big thing, either getting the burial team to come and bury them or going through the process of making sure they're ready for release, that they aren't still potentially as infectious. And still there were a high proportion of cases. So one of the things we want to look at is some places were really good and had almost complete records, other places very incomplete ones. To what extent that's biasing the results? Was that informed missingness or random? We looked at geographical synchrony in various ways, because this is one of the things, you know, we wanted to point out. So if there was an epidemic that was very short, of course, once you saw that, you wouldn't want to have set up a treatment center and have it open there, just when there are about to be no cases. But there's some places like Gekadu, which is where it started, that were consistent, you know, for this just shows the first 40 weeks, but had cases all the way through, and other places that had cases for many weeks. So, and this is from our most recent paper published under the WHO Ebola response team that shows by regions rather than district, within each country, how you saw, you know, they peaked at very different times. So you saw some peaked late and some peaked early on. And so, you know, just looking at the national numbers can hide the variation that was there. So I hope in this I've given something for everyone in the range of things that we looked at and the challenge that we met. Here's a list of things that we've published. And here there are 2 papers that are submitted, hopefully both very near acceptance, and a review article where we actually looked at the current estimates, compared them to all the estimates of past epidemics. And so finally, I want to end with pointing at the group of people that we worked with locally within Imperial, but again say, you know, we worked really hard, lots of people worked really hard in WHO and in the countries, but it was nothing compared to the people who were actually working hard and watching people die and also putting themselves at risk of getting Ebola themselves. So we're, I think as a sort of group of people, we should all be thankful to them for having controlled this epidemic, because it's such a dangerous disease, and we all benefit from their efforts. Thank you very much.
We do have a few minutes for questions, and there are 2 roving mics coming around. If people would like to ask a question and they're not at all near the front of this lecture, it'd be good to use the mic. Yes, Thomas.
So I was very interested in these plots about the RT. So on the theoretical end, various people have been thinking about whether we need a rethink on this sort of thing for sub-exponential, very near critical epidemics. So someone nearer the sharp end, would you say that's a good thing for theorists to be spending their time worrying about?
Oh, I think it is very important, because you know, in a sense, that's the sharp end of where things can go tragically. You know, when you're just on the edge, is where things are most sensitive. And one of the things, I remember this specifically from dealing with SARS, the first time we produced estimates that showed that the reproduction number had gone below 1, which I think we had conveyed, and the policymakers in Hong Kong sent back the question of, does that mean we can stop all those cancellations we brought in? No, it doesn't mean that. It's not the time to relax. So that, when you're just on the edge, I think is critically important.
Noel Cressy.
Yes, Christl Donnelly. Thanks, it's a fabulous talk. I noticed that mapping is part of the report, although you didn't feature it that much in your talk. Could you talk about the interface between R and, I think you're using Esri software, if I'm not mistaken. But anyhow, the interface between R and the mapping software that you used, and how difficult or easy that was?
Mapping was something that we only used to inform WHO. We couldn't publish any of the maps we made at Imperial. The reason for that is because WHO is an international organization, there are huge sensitivities of exactly, the exact maps that are used. So we were using sort of borders that were provided for us from WHO to make the maps in our reports, but then we weren't, so it really upset the people in the group who'd spent ages getting the maps really nice to then be told when we went to publication, but you can't use those, we have to produce the maps ourselves. So all the maps that we published were produced by WHO.